podcast is for local anesthetics and basic pharmacology. Try not to make it too terribly boring. The usual disclaimer. No financial disclaimers to report, and the majority of this information was used from the clinical anesthesia text from Barish, the 7th edition. So what we're going to be going over today, mechanism of action and site of action of local anesthetics, pharmacodynamics, additives that you can place in with the local anesthetics, the pharmacokinetic properties, and toxicity, and then Exparel is kind of the hot topic that I'll include in this as well, as it'll be something that will be relevant to clinical practice as our training residents graduate and go on to other institutions. I was going to start off with something fairly hilarious, so that in local anesthetics, or just have our patients get a discount for their surgeries by helping out and applying their own labor costs. All right, so our local anesthetics act largely on sodium channels. So all the things that are in the membrane that regulate flow of sodium in and out. So these are on nerves. And so with the local anesthetics themselves, they must be in an unionized state to cross the lipid membrane. So without that charge is the only way they can get across the lipid barrier to get into the cell, which is where their site of action is, inside the cell in the sodium channel. Once it's inside the nerve, it's the ionized state that has interaction with the sodium channel itself to provide the blockade necessary. Interestingly enough, the text also discusses on a molecular level, it's only about 1 to 2% of the total drug that actually makes it into the cell for the clinical effect that we see with sodium channel blockade and interruption of normal transmission. And so as our saltatory conduction and progression of the signal in terms of ionic depolarization down the axon, generally about 3 nodes of RANVA are the necessary segments to have blocked such that as the intracellular concentration of sodium and potassium as the ions are moving back and forth with the blockade of potential signal being propagated down to decaying transmission. So the tangential contact of the sodium channels and the voltage-gated channels that respond in the saltatory conduction, they don't continue to depolarize as the normal insulation that's around the nerve that propagates the signal is reduced with the nodes of RANVA that are blocked as 3. So the clinically important item here is that we think of sodium channels as a singular item, that it is a channel that sodium moves across in terms of a neural depolarization. It's not entirely the case. So the advantage that we have in 2015 is there's been a lot of bench research that has gone through and kind of quantified differences in sodium channels. For example, cardiac sodium channels are slightly different than central nervous system, or slightly different than nerves that are coming out like nerve roots of the neuraxis. So all these different parts of the body, whereas the overall function of that particular protein, that sodium channel, is singular, the actual structure and how it does that job is different. So the clinical relevant importance of that is that because of the different shapes of the different configurations of these sodium channels, the different local anesthetics will have different affinities for the differing sodium channels. So that's where the clinical importance of that esoteric little nugget of knowledge comes into play. So also considering that we read the textbooks and it tells us that the smaller nerve fibers are more susceptible to blockade, there have been instances of research that Barish also discusses where some of the larger myelinated A delta fibers that were mediators of sharp pain in some particular tissue samples have been found to be blocked preferentially with lower concentrations of local anesthetics as opposed to some of the non-myelinated C fibers that may be smaller. So counterintuitively, we'd think that it's kind of a linear assembly of how they work, but some of the newer bench research items are kind of turning that idea on its ear. So in terms of clinical applications of that, just kind of understanding the foundation of mechanisms of how things are working and the sites at which they're working. So it's not quite as simple as we initially had believed. So in terms of the pharmacodynamics of our local anesthetics, the pKa, the negative log of the dissociation constant, all of the local anesthetics have some degree of an alkaline type of pKa. So the clinical importance of that is that on this scale, as we have an alkaline pKa, as we become more alkaline, as the pH goes above 7.4, it exists more in an unionized state. So that's the milieu that it has to be in to get inside the nerve to the site of action of the sodium channel inside the cell. And conversely, if we have a very acidic environment, it's going to exist more in an ionized state. So that being said, that doesn't get into the nerve cell as easy. So if we have a tissue that we're trying to inject just local into that may be like infected tissue or something where the particular acidosis exists, the effect of that local anesthetic isn't going to be very substantial because it doesn't have the correct unionized state to get inside the sodium channel. So that's the clinical importance there. So the more potent agents also have more property of, they're more lipid soluble. So they additionally will have a longer duration of action as such that they are more readily absorbed both into the nerve cell itself and in kind of surrounding tissue, so it hangs out a little bit longer. So that's another effect of where we see agents like ropivacaine and bupivacaine, they're a little more lipid soluble, tend to have a little bit more duration of action within that site relative to something like lidocaine that isn't quite as lipid soluble. And then the more potent agents also, for example, bupivacaine, they have more of a binding affinity because of the shape. This is all a lock and key mechanism. So if the shape is more correct and it has more charged sites that line up and bind more properly, then you'll have more of an effect on effectiveness of blocking the sodium channels. So still going with pharmacodynamics, the concentration can overcome the potency if the concentration is high enough. So for example, some of the chlorprocaine mixtures may have more molecules per milliliter than some of the less concentrated items. So in terms of relative potency and depth of blockade, if you have an agent that has a high enough concentration, while it may not last as long, can have an equivocal amount of potency for blocking the sodium channel just by outnumbering it with sheer molecules of content. Again, like I said, that doesn't necessarily affect the duration. It'll still wash out and be metabolized. But you also have to consider where you are in the toxicity scale in terms of how much medicine you've injected, total amount of milligrams, molecules, how much you put into the body. You also have an ascending type of block where you have temperature, sensation, proprioception, the motor sharp, and then light touch kind of go out in that order. So one of the first things that you'll see me do when we're doing blockades is we'll have the patient, especially for interscalenes, have the patient try to reach up and touch your finger in space because that proprioception tends to be one of the earlier items that is taken out of the conduction pathways. They have difficulty with reaching up and touching something in space, and then motor starts to set up in their sharp pain sensation. So with all of the medications that we can add to the mixture here, we have epinephrine. So in terms of its mechanism of action, so it's an everything agonist, alpha, beta, okay? So the agent itself serves to decrease the systemic absorption because it's a vasoconstrictor. So all of the peripheral tissues that would otherwise take up the local anesthetic and redistribute them in the body have a constrictive effect, so that flow is reduced, so the overall uptake is reduced. You have an alpha-2 direct analgesic effect in terms of the pathway of the reasons that we add clonidine, we'll discuss momentarily, that those have direct pain pathway effects. Now, there's quite a bit of variability in terms of clinical use of how people have used epinephrine within their blocks. So 1 to 100,000, 200,000, 400,000. So, and remembering all of those dosing, so the quick math for that is how many times does that go into a million? So 100,000 goes into a million 10 times, 200, 5 times, 400, 2.5. So that tells you how many micrograms per milliliter you have of those solutions. Now going on in this particular slide, there were a handful of case reports and small cohorts that were published when I was residency back in about 2007, 2008, that were case reports of injuries to nerves that were believed to be secondary to higher concentrations, 1 to 100,000, 1 to 200,000, that were injected in local anesthetic solutions that did result in permanent nerve damage. So that was something that made me rethink my use of epinephrine in local anesthetics in terms of what risk of exposure we are subjecting these patients to. Now, conversely, we are also able to inject more medication because of the reduced absorption effect. So it's kind of a little bit of a trade-off. So 400,000 tends to be the most clinically commonly used when you're going to add epinephrine to your injectates, and typically we'll titrate that in the concentrated ampules, the 1 to 1,000, the 1 milligram per milliliter, and then use like a 1 ml syringe to drip in the amount that you want within your large stick of local anesthetic. So sometimes we'll put like sodium bicarbonate into solutions to alkalize it. Interestingly enough, whereas we are increasing the pH and we are giving a higher unionized fraction for entry into the cell, we've increased the rate of onset, but there needs to be care taken when you're doing this, because interestingly enough, the majority of solutions exist in a little bit of an acidic environment. So if you add too much sodium bicarb and alkalize too much, you can actually precipitate out in the solution. So it's a consideration typically in a 30 ml volume of most of the local anesthetics. If we add just a milliliter of bicarb, then that tends to not be too much. But within the text itself and actually clinical practice, paying attention to how much sodium bicarb that we're putting in that solution, and by alkalinizing as well, it will also kind of decrease some of the discomfort from that slightly acidic solution being injected. So moving on to opiates. So some bench research that had come out, I believe more in the 2009, 2010 area, did have peripheral receptors that seemed to be consistent with properties that would bind to opiates. So a lot of literature was generated during that time, attempting to use different type of opiates to prolong or sustain peripheral nerve blocks and improve the quality of peripheral nerve blocks. But the majority of those studies, through a series of kind of poorly designed mistakes and the fact that maybe clinically these aren't quite as rewarding a receptor to bind, didn't really show that adding things like fentanyl or morphine or Dilaudid or any of those things, that adding them to any kind of local anesthetic injectate really provided any additional benefit to the injectate itself. Now, some of the central nervous system receptor sets, so obviously the mu, kappa, delta, sigma, rho, all those receptors within the neuraxis, they do have a clinically substantial benefit of adding opiates within our local anesthetic solution, such that you kind of get a best of both worlds, whereas you don't necessarily have to have a higher concentration of one or the other, but by balancing an opiate with local anesthetic within the neuraxis, you kind of get the analgesic profile that you're looking for without having side effects that would be from higher doses of one of those medications. And then buprenorphine as an agonist-antagonist, again, not one of those items that I've seen explicitly described in bench research, but some of the buprenorphine studies did seem to have consistently positive results, and that is an agent that I've used for peripheral nerve blockade, and the quality of the block seems to be very satisfying in terms of the patient experience and patient report of that. But again, that's more of an anecdotal report, but it's a pretty low risk medication to inject to add to the solution. So clonidine, so this one has been very consistently shown to improve the duration of action for local anesthetics. 1 to 2 hours seems to be the common result for many of the studies that have looked at the use of clonidine and alpha-2 agonist for your A and C pain fibers. I've not seen clonidine in an injectable form in anything other than a preservative-free solution, but that's certainly something that as our trainees migrate to other areas of practice, that make sure that you pay attention to that, because that's a recommended item to have that preservative-free solution. So steroids as well. So common for peripheral nerve injections, triamcinolone and dexamethasone decadron are common agents that are added, whereas we see triamcinolone more in kind of the chronic pain clinic and using for neuritic type pain. And decadron has been primarily used in large part for peripheral nerve blocks, for prolonging the block. Interestingly enough, there were a couple of studies that came out of Britain, kind of the 2009-2011 timeframe, that were able to demonstrate that using IV routes were comparable to using dexamethasone within the solution that was injected for the peripheral nerve block. So that was an interesting kind of segue that was a pleasant surprise to have found, as the last line on the slide indicating that many of the solutions of dexamethasone that we use may include phenol and methylparaben as preservatives. So nerves don't tend to like those things quite as much, so that's something to pay attention to. If you're going to use dexamethasone, they make preservative-free solutions, and that would be the recommended dosing to use for that. Most commonly for the amounts that we use in that, typically 4 milligrams is a fairly routine dose, up to maybe 8 milligrams of dexamethasone, either IV or in the injectate itself. And for triamcinolone, I more routinely use kind of a 10 milligram dosing with that. But some chronic pain practitioners will go higher, up to like 40, 50 milligrams. So that's kind of a anecdotal report as well, but kind of a ballpark of effective dosing to kind of start with. So as we're looking at pharmacokinetics of our local anesthetics, absorption into the kind of the central compartment and where all of these medications go, intuitively you would think that the vessel-rich tissues, that things that have more blood vessels, are going to give you higher plasma concentrations. So that would be a fairly accurate statement. And then a common test question that pops up is where you're putting these injections will have a consistent manifestation of how much plasma concentration of local anesthetics you're arriving at. So intercostal and kind of paravertebral blocks are fairly vessel-rich and lead fairly high plasma concentration levels of local anesthetics, kind of in a declining fashion, or caudals, epidurals, brachial plexus, down to the leg. So this is kind of a linear approach, but a common test question that pops up. And as you would expect as well, more drug in the body equals higher plasma concentration. So that is another intuitively true statement, something to kind of point out for the pharmacokinetics of these medications. And then, as discussed previously, the more lipid-soluble agents don't necessarily leach into the circulating concentration, and so your overall systemic concentration from some of the more lipid-soluble potent agents is as expected lower. So interestingly, in looking at the kinetics of it in tissue injection models, some of the bench research has also additionally shown that the lower concentrations of potent agents, so say normally we use 0.5% ropivacaine and we cut that down to like 1/8% ropivacaine. And for the tissue injectate, at the lower concentrations, you actually get some properties of vasoconstriction. It's, again, kind of one of those push the I believe buttons from reading the text, but is something that's been a reproducible study. Whereas when we're using higher concentrations, we'll come back up to that 0.5% solution, what we'd expect in terms of our sympathectomy and vasodilation. So kind of a paradoxical response depending on your concentration of your local anesthetic. So looking at how these are also broken down, so the esters, so chlorprocaine, procaine, tetracaine, those things are metabolized by our nonspecific plasma esterases, and then the amides are metabolized by hepatic systems, P450, carboxyl esterases, so conventional routes. Interestingly enough, these enzymes are very effective at metabolizing plasma concentrations of the amides. So in terms of hepatic blood flow and IV injectate, having done some chronic pain procedures when I was a resident, where we'd intentionally inject lidocaine for some of our fibromyalgia patients, and seeing the length and duration of some of the tinnitus or metal taste in the mouth that we would intentionally get from lidocaine injection, they actually cleared that pretty quickly within like 5 to 10 minutes. So that overall kind of peak in plasma concentration of lidocaine is fairly quickly metabolized. So as we were talking about earlier in our mechanism of action, so our central nervous system and cardiovascular sodium channels have effect from these as we are increasing our plasma concentration, the total amount of drug that we're putting into the body. So in terms of how we see symptoms manifest in these patients as they're approaching toxic levels of these medications, they tend to be in kind of an ascending order where they get that ringing in their ears, metal taste in their mouth, they may get a seizure. That may also progress to coma. The EKG changes might manifest around this time, maybe even up to asystole, depending on how the concentrations come up. So as we talked earlier about the variance in types of sodium channels, that's why you see this pattern, is because initially kind of the tinnitus, metal taste in the mouth, and the seizures, those are properties of the local anesthetics having effect on the inhibitory pathways, such that you're left with more of the excitatory pathways that are really kind of having an effect on where you're getting this uncontrolled electrical activity and this manifestation of electrical storm of the brain that is a seizure. And some of the kind of artificial firing where, for whatever reason, the sensorium cloud of I hear ringing in my ears, I taste, like I've got a penny in my mouth. Those are manifestations of those excitatory pathways not having normal regulation. It's giving them kind of very specific clinical picture that we see commonly with local anesthetic toxicities. And then as the concentrations continue to go up, what we've got with our coma manifestation, EKG changes and asystole, those sodium channels don't have quite as much specificity. By increasing the concentration, overwhelms that resistance and binding, so to speak, whereas the lock and key doesn't fit quite as well, but you're just pushing the key harder into the lock, and then you get the effect from it. So that's the big part there. So fortunately, the sodium channels within the cardiovascular conduction system have a not quite as a sensitive binding affinity as our central nervous system. So that's why we see the CNS symptoms first, and then we may manifest cardiovascular symptoms as those plasma concentrations continue to rise. So the text was able to kind of quantify some of the amounts, whereas our seizure threshold might be somewhere about 10 to 15 micrograms per milliliter, depending on the local anesthetic. I think the agent of analysis here, I believe, is ropivacaine or bupivacaine. And then you have an increased concentration up to 25 micrograms per milliliter before you start to get cardiovascular manifestations. So, if you get kind of that sweet spot where maybe it's like, 17 micrograms per milliliter, you're not quite up to that 25, you might have a seizure, but you won't have cardiovascular collapse. So obviously there's no way to control that. You just kind of have to hope that if you're starting to get into that local anesthetic toxicity boat, that you kind of shoot the moon and don't overshoot into the cardiovascular collapse. So we have, lidocaine has a much safer profile for kind of separating the cardiovascular toxicity is central nervous system toxicity, where a patient may have a seizure, but you just about have to keep pushing local anesthetic in more and more lidocaine to get to the point that they would have cardiovascular collapse. Whereas you have another agent like bupivacaine that doesn't have quite as much of a separation between central nervous system and cardiovascular toxicity limits. So that's an agent where you kind of get into a bad place much quicker, just because of the way that it binds the sodium channels and how much of an attraction it has for those specific types of sodium channels. Interestingly enough, you can also have pretty notable pulmonary artery hypertension as the local anesthetic concentrations are beginning to rise, and you're starting to get some of those, central nervous system cardiovascular symptoms. There have been a handful of studies that have been able to kind of document the pulmonary artery pressures going up substantially as you're getting into a local anesthetic toxicity event. So kind of a picture snapped out of the Barrett's textbook itself, looking at the relative ratios, where as you see, you get a little bit more of a narrow ratio where your central nervous system to cardiovascular system toxicity, bupivacaine has a rating of 2, whereas something like lidocaine has a rating of 7. So that's just kind of an illustration to show where those kind of fall out in that line. Looking at even levobupivacaine or ropivacaine are a unit lower on the relative potency side, whereas we've got 2.9 for those agents relative to 4 that is bupivacaine. So just kind of an idea for how these different agents demonstrate different thresholds for toxicity between central nervous system and cardiovascular. Again, kind of that table kind of breaking down. Again, these are things that you can go back and look at for whatever access you have to Barrett's textbook. There's one in Miller. I'm sure there's one in Moore and McHale and Murray, where it kind of goes through and breaks down all of these numbers that come from bench research. So looking at relative concentrations and kind of where the fallout is in terms of their clinical profiles for these things. All right, so to specifically kind of discuss bupivacaine in and of itself, as it's the most concerning agent that we've got, it appears that the R enantiomer is the bad actor, so to speak. So specifically, it has a higher affinity than the L enantiomer, which is why they sell levobupivacaine in Europe, and it's fairly equivocal to ropivacaine. And then ropivacaine as an isomer as well doesn't have this particular property. So in addition to the R enantiomer having a higher affinity, okay, it also seems to hang on longer to the sodium channel itself into what should be kind of the repolarization phase, and so the manifestation you get from that is kind of widens the QRS. So it hangs on a little bit longer than the L enantiomer, or certainly more so than lidocaine or ropivacaine. So in terms of the timing of the binding and affecting, what should be getting into repolarization kind of holds onto it and really affects the sodium channel conductance. And so in most extreme circumstances, and from a lot of the conference lectures that I've been to describing EKG manifestations, it's almost like taking the EKG and just kind of pulling it apart, kind of like what we see with potassium in the cardioplegia solutions when we're doing cardiovascular and heart cases. Just kind of stretches it out, and then conductance is gone. So that's what EKG changes can manifest as we're getting cardiovascular toxicity. So in terms of how we treat toxicity should this happen, intralipid is the agent that's been identified as the medication that has the most, or actually really the only ability to kind of have an effect on the local anesthetic, so that you either get return of spontaneous circulation should you have a full-blown cardiovascular collapse, or to provide some sort of safety net so that if you're starting to head in that direction, that you've got a rescue step that you can take to keep from getting to cardiovascular collapse. So as indicated kind of on the top line here, there are only a handful of patients that ever survived from local anesthetic toxicity, and the only way that they survived before the discovery of intralipid was cardiopulmonary bypass. So intralipid is a 20% solution. Okay, initial dosing from kind of some of the expert panels and what's listed in the last recommendation is local anesthetics assume toxicity, so about 1.5 to 2 milligrams per kilo, or milliliters, sorry, per kilo, so not milligrams, milliliters. The dose may be repeated 5 minutes after the initial, so you can repeat that 1.5 to 2 milliliters per kilo if you're not getting return of spontaneous circulation. Then the infusion can be started at 0.25 up to 1 milliliter per kilo per minute until return of spontaneous circulation. So if you are able to get to that person to the point that they've got return to spontaneous circulation, the infusion recommendation is to run it for at least 10 minutes after the return of your blood pressure and heart rate. Okay, from the last website, it looks like that their kind of standing recommendations have been up to 10 milliliters per kilo. But in going to the ASRA conference and listening to Guy Weinberg, who's the kind of the discoverer of intralipid and its biggest proponent, they've had lab animal studies where they've gone up to and above 20 milliliters per kilo. And in the lab animal models, there don't seem to be any kind of untoward effect from giving higher doses of intralipid. So from a standpoint of overdose and risk, it doesn't seem to be quite as much of an overall concern around these dosing frames. Certainly, you're kind of starting in a bad position, and really the only direction you can go is up. So from a standpoint of giving the intralipid, these are kind of general dosing guidelines based off of animal resuscitation models, but certainly the literature is blooming with incidences and case reports of patients being rescued from central nervous system, cardiovascular, local anesthetic toxicity issues, that this has been a very beneficial drug for treating these patients. So getting in the home stretch here, so Exparel is the new kid on the block. So it is bupivacaine, okay? So it is bupivacaine in a liposomal package. So it is racemic, so it has the R and L enantiomers. It comes as a 20 milliliter bottle. It's a 1.3% solution. Okay, so looking within what's in the bottle, that's twice what we commonly inject for regional anesthetics at 0.5% solution of ropivacaine or even bupivacaine for the most common regional anesthetics that I perform at the University of Kentucky. The volume of injectate, I'd have to go back and look at the manufacturer recommendations, but you can dilute it down to like hundreds of milliliters of solution. So a lot of plastic surgeons have used this, again, anecdotally, for kind of some of their venous stripping and harvesting, where they've put some of these larger volumes in and kind of had to spread it over more surface area, but seems to clinically be effective in reducing postoperative opiate needs and good for analgesia. Now, the manufacturer will advertise this up to 72 hours of analgesia. I used this when I was in the Army before I separated. I felt like patients were getting pretty good pain relief from it. We're using it as clinically indicated by the FDA for bunionectomies and for hemorrhoid surgeries, and it seemed like they were getting over 2 days of relief, but not quite a full 3 days. So that seemed to be kind of the clinical meeting in the middle of what the manufacturer tells you and the reality of how the medication tends to give analgesia. Now, there have been several reports that have been kind of FDA studies and investigative studies looking at plasma concentrations of bupivacaine in patients that have gotten Exparel. And in some of the reports, again at the ASRA conference, that this is kind of a hot topic of discussion, there have been plasma concentrations that have been reported in the tens of thousands of micrograms per milliliter, which should be in toxic ranges. But according to the study reports and the investigative, and this is a lot of the data that came back from initial FDA trials, there were no central nervous system or cardiovascular toxicity symptoms reported in these patients, whereas the numbers should have been off the scale relative to what we expect. So I find that very curious and perplexing, but I don't have a good answer for that. The best confabulation I can dream up is that with some packaging effect of this depot foam, this lipid molecule that it exists in, that you're getting some sort of additional kind of safety binding of the bupivacaine itself, so that whatever makes it into plasma concentration isn't a clinically effective form, that it somehow still stays attached to the lipid molecule and doesn't have a sodium channel effect because of what it's contained in as it's injected. All right, so that's about all of the clinically relevant and board testable material that I think that can be absorbed and is thrown at you. So thank you so much for your attention, and I'm sorry I don't have another clever slide at the end of this to keep you entertained, but at least there's a delightful picture of me putting blocks in while I'm in Afghanistan. You can't see my upper body because it's camouflaged, but that is all.